My name is Scott Graham, and I just, in the moment, got an advanced degree. I'm not really a doctor. I just play one on TV. I have a master's degree in psychology and an MBA. I do not have a PhD. But pleased to have Dr. Uzma on the panel today, and she's going to assist me in talking about challenges in the USA and challenges in Pakistan that relate to psychiatric rehabilitation. And you probably couldn't see from the small print in my bio, but I've been involved with psychiatric rehabilitation for probably since 1980. Aha. Okay. Since 1980, and was involved with the first Train the Trainer program at Boston University in psychiatric rehabilitation. The organization I was running that time in Florida got involved with that program, and we were one of the first 3 organizations in the United States to get involved. So although I didn't get trained in psychiatric rehabilitation, I kind of absorbed it as my staff went through the training and got that training from our trainers from BU. And so I have a pretty good familiarity about psychiatric rehabilitation. And along the way in my career, I went back and got a master's in business administration, which kind of helped me to understand the value, financial value, of psychiatric rehabilitation. But I'm not going to talk about that today. I've been charged with talking about the challenges to psychiatric rehabilitation in the United States. So be prepared for a couple of weeks of presentations here, because we do have a lot of challenges. And then I think Dr. Uzma is going to talk about the challenges to psychiatric rehabilitation in Pakistan. So I don't think you can understand the challenges in the United States in psychiatric rehabilitation without understanding a little bit about our past and how we've developed over the years. Tony did a great job in doing a broad overview of some of the things that have happened in the United States, but I wanted to talk specifically about psychiatric rehabilitation and how it's evolved in the United States. And let's go back to the 1940s. So back in the late 1940s, as Tony has talked about with the recovery house folks, there was a gentleman by the name of John Beard in New York City. And John was a young social worker, and he was hired by an organization that wanted him to work with a group of people who had been discharged from a gigantic psychiatric hospital in New York City. And he did that and met with them in several locations. And he was an entrepreneurial kind of guy and actually got some funding and bought a brownstone in Manhattan in New York City, and it had a fountain in the backyard. And what do you know? It became Fountain House. And that was the first clubhouse program in the United States. And they met and they started the clubhouse model. And initially, the clubhouse model had 3 vocational units. The culinary group, people learned how to fix meals for the rest of the members, and they called themselves members of the clubhouse. They had a janitorial group, and the members actually helped clean the facility at Fountain House. And they had a clerical group that actually produced a newsletter and other documents for Fountain House and for the clubhouse. And then several years later, they started this concept called transitional employment. And basically, Dr. Beard and his cohorts went out into the community and made arrangements with employers that said, you know, we'd like for you to hire some of our folks part-time for 6 months to give them the opportunity to experience vocational services out in the community. And of course, because of stigma, those employers they're saying, well, I don't know if I really want to do that. And here was the rub. Fountain House said, well, listen, we know you're a little nervous, but we'll make sure that we have one of our staff people out with the person initially every day to make sure they're doing well and to make sure that you're comfortable with how they're performing. And then you could call us anytime that you need us to come out and support the person or respond to your questions. And it turned out to be a national model at its time. And it was the precursor to supported employment, which you've already heard of this morning. Over the years, the clubhouse model has evolved. It's added research unit, which the members actually do research based on data that's collected in the clubhouse. They've added an education unit. Tony talked about supported education. Well, this was the Fountain House way of actually doing education for the members in the clubhouse. They've added an employment unit, which actually has prepared people to go out into those transition employment opportunities. They've added a horticultural unit. Does that sound familiar? Yeah. Folks in Recovery House, you do that training? Yeah. And they've also added a reception and membership unit to the clerical unit so that people are trained in how to greet members or visitors and how to sign people up for membership as part of their intake process. So it's evolved over the years. There's also been significant replication of the clubhouse model over the years. Back in the middle 70s to 1980, there was some federal funding involved that could replicate the Fountain House model, and some of that funding helped start organizations in Philadelphia, Miami, New Jersey, Ohio, Pennsylvania, Chicago, St. Louis, San Diego, and many more. And then those organizations took federal funds and trained even more organizations throughout the United States. And that's how I got introduced to the clubhouse model in 1978 or 79. So we actually trained at Fellowship House in Miami, and our staff went through 3 or 4 weeks of training at Fellowship House and came back and started implementing the clubhouse model at Bowley Centers in St. Petersburg, Florida. And over the years, there have been organizations, including the one that I ran, that kind of made variations on the theme. And the clubhouse folks actually created their own international association and their own accreditation for clubhouse activities. And some organizations actually broke away from that model and began to doing some other innovative stuff like consumer-run businesses, supported employment, which you've heard about today, housing. Initially, Fountain House did not offer housing for people with psychiatric disabilities, but organizations decided that, affordable housing for people with psychiatric disabilities was so important they needed to get into that. You can't really focus on recovery if you don't have a roof over your head, and so that became a big part of some of the organizations and their vision and mission. Supported living, actually helping people to find their own places in the community and then finding staff support that would go out to help them in their own homes. Skill classes actually comes from the Center for Psychiatric Rehabilitation, and Psych Rehab, according to the Boston University model, actually believes in skill classes in physical, intellectual, and emotional skills that people need to recover. And so organizations like the one I ran in Florida had our folks go out and learn those skills and how to teach them to people with psychiatric disabilities. And specialized services for seniors. Organizations got tired in the United States of seeing their seniors go into nursing homes, and so they developed specialized services for seniors that including nursing service, and so people stopped going into nursing homes and were able to live their lives at the community support programs that were more normalizing. Case management, which is a concept that you may have here in Pakistan, but basically professionals that take care of the social needs of individuals with psychiatric disabilities. And finally, just to name a few of them, outpatient treatment, actually, where people can come and get therapy and come and get their medications that help them remain stable. The traditional fountain house does not provide a lot of these services, so it's interesting that there were a lot of professionals who ran organizations out in the community that were seeing the need for these specialized services beyond the fountain house model that decided to find the resources to create them. And many of these initiatives were created by federal and state initiatives called Medicaid. In the United States back in the 60s, President Lyndon Johnson was the president, and he had a great vision for healthcare in the United States. And so back in the 60s, and I believe we celebrated the 50th anniversary of Medicaid and Medicare in the United States. And Medicare primarily provided services for seniors and people with severe disabilities who had actually put in time into working and had money taken out of their pay, matched by their employers, which would then go to them if they became disabled or as they turned 65. Medicaid was set up to provide the same kinds of services for people who were poor, impoverished, or had disabilities and hadn't contributed to the taxes for Medicare. And so slowly but surely, those revenue sources, those programs began to filter into behavioral health in the United States. And it was a wonderful thing, but even that wonderful thing has its challenges, which I'll get into in a little bit. So Medicaid in the United States is funded by a partnership between the federal government through an entity, and this is really not important to you, but Community Medicare and Medicaid Services, which is part of the Department of Health and Human Services in the federal government. And states actually have to match at some percentage the money that's given to them by the federal government. And through the Affordable Care Act, which was passed during the Obama administration, and some of you may know as Obamacare, actually reduced that match to 25%. So a lot of states who wanted to buy into the Affordable Care Act are receiving a lot more federal money than they did before the federal Affordable Care Act, and it is helping them to expand services to more people and also expand the range of services that are provided in the states. And believe it or not, there were actually some states that chose not to buy into the Affordable Care Act and have essentially said, we don't want this money. So the problems, as Tony said this morning, if you've seen one mental health system in the United States, you've seen one, because every state is different, as he said this morning. Every state has the right to change or approve or put on the menu what they want to cover with Medicaid funds. And that really is a wide range throughout the United States. Some states don't want to cover a lot because they don't want to spend the money on match. Some states are far more generous because they have the revenue to do so and can pay for the match. And so you'll see a wide variety and range of services for people with psychiatric disabilities depend on which state you go to. The other factor is states get to set the rates. So Medicaid, let's make it simple. Let's suppose somebody is in a residential program and they're getting psychiatric rehabilitation during the day, and they're going to see their doctor in an outpatient clinic once or twice a week or once or twice a month. There's a Medicaid rate that pays for the staff services in the residential program. There's a Medicaid rate that pays for a day of psychiatric day programming, and there's a different rate that pays for outpatient services. States can set those rates differently, and again, the devil is in the detail of what those rates are, because there's only two things that can impact how much revenue an organization that provides services can get from Medicaid, and that's the volume, the services that they provide, and it's the rate that goes along with the service that's provided. So for some smaller organizations, it's really difficult to get by if the rate's very low, because they don't have the volume that is necessary to support the services that they want to provide. Large organizations do have the volume, and they can sometimes get by with the smaller rate because they have a lot of volume, they serve a lot of people, and really helps them to provide those services. Not only that, but gives them extra revenues to do some really interesting things. And the other detail is that states get to determine how frequently they increase those rates. So what if you have a very stingy state legislature, and we have a lot of those right now, or you have a very stingy governor of a state that isn't really interested in psychiatric rehabilitation, and the governor has a lot of power to set the state budget? Well, an organization or a mental health system couldn't go for a very long period of time without a rate increase that pays for those services. And if you think about a steady flow of revenue, but your costs continue to go up year to year, then something's got to give, right? And usually that's quality of services or the quantity of services. So that's one of the challenges that we have in the United States with Medicaid. And as nice as Medicaid is, it still has a double-edged sword. I'm sorry? Oh. Okay. Prior to the introduction of Medicaid, most organizations were really dependent on grant funds from the federal government and from the states. initially, Tony talked this morning about the Community Mental Health Center Act. Well, that allowed for a lot of federal money to flow from the federal government to the states to community mental health programs to provide some very important services. And things went along fairly well, although that vision set by President Kennedy never did realize his vision of having one of those service centers in every community in the United States. Never got to that because there wasn't enough funding. And in 1980, when President Reagan became president, he essentially dismantled all of that and turned that money over to the states so they could do with what they wished. And that was pretty much a disaster. And it really was a problem because states are all different. Some states wanted to spend the money on certain things. Some states wanted to spend money on mental health. And it became a problem for the community mental health system. So to deal with that, states began to look at Medicaid as a vehicle to fill that gap. And it took maybe 10 to 15 years, but now Medicaid is probably the most significant portion of the funding that funds behavioral health services in the United States. In substance abuse in the United States, it's been slower to convert to Medicaid. They've relied on grant funding, and that grant funding is almost gone now, and they're having to convert to providing their services on a fee-for-service basis through Medicaid. And it's been really problematic for a lot of them who've been living on grant dollars for the last 20, 25 years. However, one of the nice things about Medicaid, as I said before, and I experienced this as an executive director in a large community mental health organization that went through the transformation of actually funding services for Medicaid after grant system. And I hope you won't take this the wrong way, but it allowed us to be, and this is my MBA speaking, it allowed us to be much more market-based in terms of meeting the needs of the people in our program, because I didn't have to ask for permission any longer to set up programs. I didn't have to ask for grant money and justify what was needed. I was able to, if I could figure out a way to fund it through Medicaid, I built it and they came. For example, I talked about senior services. We got tired of seeing people go into nursing homes, so I said, let's build elder options. Let's build specialized residential services for these folks who have somatic needs as well as psychiatric needs. And let's build a specialized day program for seniors where there are nurses and who they can deal with diabetic issues, they could deal with wounds from diabetic problems, they can deal with giving people sticks every day for diabetes, taking their vitals every few hours if they needed it. That did not exist in the state of Maryland where I came from. So we were pioneer, and only because of the flexibility granted to us by Medicaid, because it paid for those services. There were silos between the treatment of substance abuse in the United States and the treatment of mental health. And I was taught from Boston University that you treat people holistically, so that was never acceptable according to me. And I said, we've got a substantial number of people in our program, in our mental health program, who have co-occurring disorders, and they need specialized services. So we set up specialized substance abuse and mental health residential programs and day programs for the population, and helped them stay out of the hospital and kept them alive, quite frankly. We wouldn't have been able to do that without Medicaid funding, because it gave us that flexibility. So I want to talk a little bit about current developments in the United States, and then get from that to kind of challenges that we have presently. I mentioned that we're moving to Medicaid coverage for substance abuse, which I think is a good thing, but there's been a lot of resistance from substance abuse providers. I think the ones that get over it and survive will actually be quite happy with it because of the flexibility it will provide to them. I think it will give them an opportunity to develop specialized residential programs for individuals at certain levels of treatment that they haven't had before. I think it will give them the opportunity to do what I did in the mental health system, and that's set up specialized services for people with co-occurring disorders that they haven't been able to do before. So eventually, I think that's going to allow us to break down those silos between substance abuse and mental health issues. The other thing that's going on is that we're looking more at integration between psychiatric rehabilitation, mental health services, and somatic issues. We have this concept called health homes, which is about 10 years old, and essentially it is a medical case management model that is actually developed and implemented by mental health programs in the community, where there is a RN who serves on the staff and actually assesses the healthcare needs of people with severe psychiatric disabilities, and then refers them to places in the community where they get help for that, and then monitors those activities and makes sure that people are actually benefiting from those services. That is also paid through by Medicaid. So we're looking at integration. There are pockets of excellence in the United States where organizations have assimilated healthcare and healthcare for somatic issues, mental health, and substance abuse disorders all in one, and Kathy talked about that in her session. And that's a real plus, I think, because if you can have somebody that can come in and get their blood pressure taken and go down the hall and get their medication checked for their psychiatric disabilities, they can do that all in one visit, particularly in places where transportation is difficult. That's a real plus. And so we're seeing that evolve in the United States. And I don't know if I mentioned this, but I've been a surveyor for CARF, which is an international accrediting body for behavioral health issues, for 18 years. And it's the standard for excellence in behavioral health care in many, many more countries in the world. And I can tell you that it does have an impact on the quality of care. And Recovery House, as you heard this morning, is committed to getting that accreditation. And I believe within a couple of years, Recovery House will be the first CARF-accredited behavioral health organization in the nation of Pakistan. And I intend to help them get there. I promise you. So, CARF believes in continuous quality improvement. We believe in outcomes management. And frankly, before accreditation through CARF, programs really didn't understand what outcomes management really meant and how to measure outcomes to know whether you're successful at being effective as an organization, being efficient as an organization, ensuring that you provide decent access to services, and ensuring that people were satisfied with the services they received. But accreditation actually forces that on an organization, and that when you actually know what you're measuring, actually analyzes that data, it helps you to improve the quality of your programs on an ongoing basis. So that's going on. Matter of fact, in my home state in Maryland, there's a mandate going on right now, and the plus is all the stuff I just told you, but there are going to be a lot of smaller organizations that aren't able to meet that mandate, and they're going to need to find partners, larger organizations that are accredited, or they're going to go out of existence. And for the poor substance abuse providers, they're actually dealing with a transition from grant system to going to a Medicaid fee-for-service system. At the same time, they're being required to seek accreditation. And for a lot of them, it's really, really difficult task. And one of the things I'm doing right now is helping those organizations prepare so that they can survive this transition. How many of you have heard about the opioid crisis in the United States? Yeah, it's really serious, and more than 33,000 people died of opioid overdose in 2015 in the United States, and that number has increased, although there aren't solid statistics, increased in the last couple of years. So states have declared an emergency and are adopting ways to deal with it, and it's something that we need to address. And as Tony mentioned this morning, there's an increase with people with psychiatric disabilities in our jails or prisons. And he mentioned this statistic about more than half of those incarcerated in local jails and state prisons have a mental illness. I mentioned the move to integrate behavioral health care, substance abuse, and somatic health that's going on. The next one's really interesting, and because you don't have a program like Medicaid in your country, you won't understand the panic that is being caused by the discussion of having Medicaid payments related to outcomes. So for those organizations that haven't been accredited before and haven't had to deal with accreditation requirements for outcomes, having to prove that you're doing a decent job to get paid through Medicaid is a really scary proposition for most behavioral health organizations. And finally, because of the Affordable Care Act, we've traditionally had people recycle through our emergency rooms in our community hospitals, and it's become a revolving door. And those individuals are our highest cost users in our health system. And the Affordable Care Act said, listen, we're going to provide you with an incentive if you can actually impact on the number of people that are coming through within 30 days for a readmit. However, if you can't improve upon that number, then we're actually going to fine you for the number that you haven't been able to reduce. And so that's happening right now. And I have to tell you, because I did some consulting with a large health system in Baltimore, Maryland, that they had one of the highest 30-day readmits in the state. Even after consultation with them, they refused to implement the very simple kinds of solutions we gave them in order to bring that down, because I don't think they had the capacity to really think beyond what they were doing on a day-to-day basis, which is really sad. Our systemic responses to some of these events, although the U.S. government realizes that there is a crisis, and even the president, who shall not be named in our country, has said it's a crisis. There are no plans to deal with that crisis on a federal level. There are states that are doing some good things. The Ohio Governor, John Kasich, actually maybe went a bit too far by essentially banning the prescribing of opioids for pain in the state of Ohio. Kansas, which is not necessarily known as a progressive state in the United States, has had for years a way that they can track the prescription of opioids and actually analyzes that data on a regular basis to determine where the pockets of overprescription are for opioids. And that has really helped in the state of Kansas deal with the crisis. So that's a couple different responses. I think I would like to see the federal government step in and provide some funding for research and interventions. But I really do think it's going to be the states that will have to, and even municipalities in the United States, that are going to have to step up to deal with the issue in the next few years. In terms of incarceration, we again have pockets of excellence in the United States where drug courts and mental health courts have been set up that help divert people from jails and prisons for drug abuse offenses. And Tony talked about his living room, which is a great concept for diverting people from prisons and jails. And there are also some pockets of excellence throughout the United States, and I see them as I go on car surveys, where community mental health programs have actually gone into prisons and jails and developed plans for the reentry of those individuals into the community that includes making sure those individuals get treatment the day after they are released from a jail or an institution. And that really has had an impact on reincarceration. And integration, many states are moving towards integration of substance abuse and mental health services, as I said. And we have a concept and a service delivery system called federally qualified healthcare centers, which are funded by the federal government. And up until about 10 years ago, they just provide somatic health care. But now any new federally qualified healthcare center that's set up is required to actually deal with substance abuse and mental health issues. And that is a wonderful thing, because those centers get funded much better than community mental health organizations in the same communities, which is a rub in those communities. So outcome-based compensation, there hasn't been a lot of guidance from the federal government or state governments at this juncture. However, we have a very active national provider association called the National Council for Community Behavioral Health Care that has actually put on seminars and trainings for its members to guide them in how to prepare for outcome-based compensation. And I would suggest, if you're interested in that concept, I really don't know why you would be, but if you're interested in that concept, you can Google National Council for Community Behavioral Health Care and find out about their efforts to actually educate providers about outcome-based compensation. And in terms of developing outcomes that will meet that, CARF, as I mentioned, the accreditation body, is leading the way in helping organizations develop outcome-based systems. And I just talked to the Recovery House folks on Friday, my first day there, about setting up an outcome-based management system and they'll need to do that for CARF, and that's going to happen within the next 3 to 4 months at Recovery House, and they'll be a model for every other behavioral health organization in the nation. And we talked about high-cost users. One of the suggestions that we had for the hospital system in Baltimore, and Tony talked about his living room and using peers. Well, one of our suggestions was, why don't we use peers to kind of follow or shadow individuals that are high-cost users and go back to the hospital every 30 days or more frequently and kind of be their friend and say, are you having a bad day? Are you thinking about using again? Do you want to do an overdose? Well, let's talk about that. Maybe we'll find something else for you to do that's a lot more positive. And that's a way, one intervention we can talk about to help with that going back and forth through the emergency room in our systems of care. Our current challenges. We're trying to cope with a vast array of issues, including the opioid crisis, including mandated accreditation, including the ER readmits, including the prospect of outcome-based funding, including the mandate for integration of substance abuse and mental health and somatic care, homeless for the mentally ill. It seems like an incredibly insurmountable problem, but there are ways to deal with it, and I think it's just a prioritization of scarce resources into that intervention. And you know, my philosophy, because I was always really big on developing housing for people with psychiatric disabilities, if you put your mind to it, you can find the resources to develop that housing. And I think in my career I've developed over 500 beds for people with psychiatric disabilities in 2 different states. And it's just because our organization had that as a value, and we found the resources, and it is doable. And finally, as you know well, funding issues today, despite our Medicaid system, are significant. And, you know, we can't just be about being service providers. That's not enough. We have to be advocates at the local, at the regional, and at the federal level for these folks. It has to be a vision, it has to be part of our job, it has to be every day. We have to persist in finding the resources that are necessary to serve this population. So we also have, as you have, staffing issues. Turnover in community mental health programs in the United States run as high as 40% a year. And what does that do in terms of the quality of services to the people that we serve? Well, it dilutes the quality of care because of that turnover, because people just start to get a relationship with somebody who's a practitioner in a program, and that person leaves. And that's a problem. And where does that go back to? It goes back to that resource issue and funding issue that I talked about. We have really poor pay for entry-level workers. Maybe you can appreciate that. People don't come to our community mental health, our psychiatric rehabilitation programs with a lot of specific training in psychiatric rehabilitation. I dare say most employees in psych rehab programs in the United States don't come to the programs with any training in psychiatric rehabilitation. We have maybe 2 or 3 schools in the nation that provide training in psychiatric rehabilitation. So basically, providers have to train their own, as Recovery House has been doing for the last year or so, providing intensive training. And that's a real commitment for an organization that has all these other service delivery things that they need to do at the same time. So it takes some vision it takes some commitment to provide that internal training program that we need, that the person serves need in order to move towards their recovery. I started an organization in Maryland in 1983, and I brought with me one of the trainers in psychiatric rehabilitation from Florida, and she became my program director. And from day one, she was responsible for beginning that training program in psychiatric rehabilitation for new employees. And it took probably 3 years for people to get through that psych rehab training and complete all of that training. And interestingly enough, we began collecting data on our average tenure of staff. It was 3 years. But those people gained skills over the 3 years that they provided to the people that we served, and we had them for that period of time. But we were training people to go on and get better jobs. Rising tide floats up all the boats. I did not feel bad about that. Matter of fact, I felt really good about making the effort. One of the things you might want to think about as recovery houses thought about is as you go off and start your own organizations in the community to provide psychiatric rehabilitation, think about your commitment to your staff and to the people you serve, and have a vision for creating that internal training program for your staff members. We're also faced with the challenge of high cost of benefits for our employees, health insurance premiums that most organizations pay a part of for our employees. It's become increasingly more difficult to actually pay for those benefits for employees. We, as I said before, have conservative state governments, which affects reimbursement rates, siphoning off of scarce resources for expensive state institutions. Many states have actually shut down, closed, or reduced institutions, but there are other states, like my home state, that is still fifth in the nation in per capita spending on antiquated state hospitals. And that takes money out of the services that are provided in the community. So with that, the fact that we don't have those funds available, it really limits our ability to be creative and to start new programs. So what does the future hold in the United States? Well, I think there's going to be significantly more accountability for funding. There's going to be more demands for funding. And so even though providers don't like it, I think it's going to be important that providers actually demonstrate that they're providing positive outcomes for the funding that they're going to get. There's going to be increasing demand, and more states are going to decide that they are going to demand accreditation. I think there's going to be a lot of consolidation of service providers and mergers and acquisitions in the United States because it's going to be more difficult for smaller providers to actually survive. And technology, we haven't talked about technology, but I think it's really going to be incumbent on psychiatric rehabilitation providers to become technology savvy. We have a movement, a very slow movement in the United States about community mental health and psychiatric rehabilitation providers to move towards electronic medical records, which I've been a big fan of for 20 years, but a lot of organizations have not gone on the bandwagon. I can tell you and tell them, and I do tell them a lot, that they have potential to save 20 to 25% of their scheduled man hours because of the implementation of electronic medical records. We spend thousands and thousands of hours in our programs actually looking for things in paper files and paper records that are eliminated by electronic medical record systems that can print out a report in seconds. And so ultimately, I think most organizations will get to the point where they see that's not an expense to invest in that electronic medical record system, but it's an investment in the future of the organization and the quality of care that people receive. And I think that the data that we get out of the systems much more quickly will allow us to be successful in continuous quality improvement, and that patient-driven care will increase dramatically because of technology. Even people with severe psychiatric disabilities will be able to plug into a consumer portal and those electronic medical record systems and be able to access data that's relevant to their situation, be able to see what their treatment plan or rehabilitation plan is in the moment, and see how they're doing in terms of their recovery just by logging into that program. And having that information on an in-the-moment data for people in recovery is so important to their recovery process. So our future challenges are funding, continued workforce challenges, trying to impose upon universities to actually teach courses in psychiatric rehabilitation, to actually set up those systems in their university systems. And I think we want to make sure that we have psych rehab resources diverted to our causes. And we, because of the probable consolidation of providers, when that happens, we need to make sure that we still have access for as many people as possible in our collapsing systems. And one of the things we're doing in the United States that's dealing with that issue, and particularly in some of the rural areas, and something that I think is probably being talked about here in Pakistan, is telepsychiatry. Using telepsychiatry to reach out to people that can't make it into current outpatient clinics. It's becoming more and more popular, and the cost is going down and down. We'll see more of that in the United States, but the challenge is to get over the hump and actually implement it. And so there are competing resources in the United States, the opioid crisis, the AIDS crisis, and finding the funding that we need to actually do some of the things like buy mental health, electronic mental health records is going to be a challenge in the future. And going back to my favorite topic, I think we've got to actually do more in terms of dealing with the challenge of providing housing for people with psychiatric disabilities and to end homelessness in the United States.